Good afternoon, everyone. I see it is noon, so we will get started. Welcome to the first webinar of our four-part Dementia Across the Spectrum webinar series hosted by the Office of Lifelong Learning and Physician Learning Program at the University of Alberta. My name is Rose Young, and I am an associate professor for the Division of Endocrinology and Metabolism and senior medical director at the Office of Lifelong Learning Physician Learning Program. So we are committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. So today is the eve of Earth Day, and I want to acknowledge that the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehayo, the Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe, lands that are now known as part of Treaties 6, 7, and 8, and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. Some housekeeping information. Please use the chat feature if you have a question about technical difficulties or L3PLP programs and services. If you have a question for the speaker, please use the Q&A function next to the chat feature on the webinar. You can review what has already been asked and upvote the questions you would like answered. And due to time constraints, we can't guarantee that the panelists will be able to respond to all the questions. A recording of the webinar will be sent to email to everybody that registered, and participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. For more information, you can access via the QR code. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. MainPro Plus participants may also earn additional certified credits by completing a linking learning exercise. So today we are very pleased to welcome Dr. Diana Rucker, who will update us on mild cognitive impairment to mild dementia, including diagnosis and treatment. She is a clinical associate professor at the Department of Medicine here at the U of A. She completed her medical degree at the University of Calgary and subsequently completed training in internal medicine and fellowship in general internal medicine at the U of A, followed by a fellowship in geriatric medicine at Harvard. Her academic interests focus on decision-making capacity, particularly its impact on hospitalization and cognitive outcomes among socially vulnerable populations, including individuals experiencing houselessness. Thank you very much for joining, and I'll hand it over to Dr. Rucker.
Hello, everybody. I'm just getting set up. Sorry, I'm always a little bit of a techno moron, but welcome to this talk. I hope you will find it useful, and I would love some feedback at the end. I do have to declare a very small honorarium I recently got from Eastside, a drug company where I was invited to be on their advisory board just this past spring. As you know, this is a four-part webinar series on dementia and some related dementias as well as capacity assessment. So today we're just going to talk about mild cognitive impairment to mild dementia with diagnosis and treatment. We'll go through some terminology. How do you diagnose dementia and what the clinical features are, and what are my treatment options when I see these people in clinic. So I just wanted to go through the terms because they're sort of changing a lot. Dementia, of course, is what I learned through in medical school, and it's cognitive impairment that affects daily function. It's very stigmatizing, so you have to be careful how you say it. Like I would always say, Mrs. S is suffering with or from dementia. But, in the news right now, if you listen to as many podcasts as I do, when they say a certain president in the South who's acting so demented, it's very stigmatizing. So the newer term, for that reason, that DSM-5 has replaced it with major neurocognitive disorder. And that's replaced it. I'm a little bit torn about it, I'll be very honest, because when I was in medical school, I remember that we had a nephrologist teaching us, and he specifically, the Nephrology or Kidney Foundation changed the term. I think back then it was acute renal insufficiency to acute kidney injury, just because so many people didn't know they had a problem with their kidneys. If you said you have renal insufficiency, and those are things we often overlook. So my general approach, because I don't want people coming into my clinic and out, is I say, yes, your loved one is suffering from dementia, and I'll go to like what kind of dementia it is, whether it's Alzheimer's. But if, say, for my patient, if they're very nervous and paranoid, I really like using this term major neurocognitive disorder because it is less stigmatizing. I read a recent paper in Lancet and it said neurocognitive. It's sort of a little bit weird. Of course, neuro is going to be cognitive because they're sort of talking about the same thing. So they just thought it was redundant language. But for now, major neurocognitive disorder. Cognitive disorders are just all the conditions and diseases that cause cognitive impairment. So Alzheimer's disease, vascular disease, alcohol-related disease, Parkinson's disease with dementia. MCI is mild cognitive disorder with normal functioning. And so the other term would be minor neurocognitive disorder. Mild behavior disorder is, again, normal functioning. And this is something I've just recently become. I mean, I knew it was there, but I've sort of had to restructure my brain and how to organize it because it's quite important. And then there's subjective complaints of cognitive impairment with normal cognitive screen and normal functioning. So this is when someone comes in and says, "Oh, I'm so forgetful." And then the worried well are just people who are worried because maybe they had a loved one or their mom and dad went through this or their sister. So let's start off with a case study. I thought I'd be kind of a little bit have a funny name, and I called her Mrs. Forgetful. She's a 75-year-old female with hypertension. The kids are worried. She's sometimes repetitive and she has difficulty with hearing. She lives alone and she has full ADLs and IADLs. And just for those who aren't familiar, these are my functional things like BADLs or ADLs, as I just call them, as activities of daily living. And then IADLs are those higher things we call independent activities of daily living. Would you do a cognitive screen? This will be our first, and we'll take a little, when would you do a cognitive screen? And I'll get people to take a little poll on that.
Okay, results are up.
Oh, oh, I set a timer for this. So people said all of the above, and I totally agree. Um, yes, these are all things like if you have people who are missing appointments, they're not really taking their medications correctly, they've been victimized by financial scams. I would do a cognitive screen. Oops, sorry. Now, our Canadian consensus guidelines for dementia say not recommended for asymptomatic people, even if there's a family history. And then potential trigger symptoms include a change in previous function. So that's always such a good thing to keep in mind. Well, what were you doing before that was normal? You probably heard of all of this. The MMSC is in many, many languages, was probably the first one around. It can be adjusted for their social economic status and age, but it's not very sensitive. And part of this is because it doesn't test executive function. And the other part is for the recall, which is one of the earliest things you'll see in dementia over and over, is it only asks three things and then it gives a very short break and it comes right back to it. Now, the MOCA came along and it stands for Montreal Cognitive Assessment. It's nice that it's Canadian. It's also very well tested in many subtypes and languages, and it's much more sensitive for mild cognitive impairment because it asks those five, objects, it has a longer break between them, and then you have to repeat them. Um, when I was training, one of our professors said he was trying to push through a test where you had at least 8 words of recall. And I remember thinking, oh dear, I would be in trouble. Now, the American, or what the Americans like to think, this is a horrible acronym, SLUMS, but it stands for St. Louis University Mental Status. Um, it's also multiple language, but it's not as well established. It is sensitive for MCI. My own personal experience. So what happened when we started our Connect Care, the MOCA wouldn't allow us to use the MOCA because they also wanted money for it, or they wanted people to, it just wasn't allowed to be used. So AHS quickly switched to the slums. But my experience, and this was right in the pandemic, the executive function is kind of worth 8 points at the very end. And it's sort of reading a paragraph and then asking people, well, what happened in that story? And it depends on, hearing the details. And I think that we have so much hearing impairment in our elderly that people rely on lip reading. So my own experience was that with the slums, it would be like consistently 5 to 7 points lower than a MOCA. If I got a 13, I wouldn't even be phased anymore. I wouldn't go, ooh, that's bad. The Rudis is an excellent choice if you have someone who can't speak the English language as well or hasn't gone very high in education. It's really simplified. All of these tests are out of 30. The Inter-RAI is also a test out of I've never used it, but it's also out there. It's one of the tests that's used on the Alberta Blue Cross forms, and I'll touch about that in the next one. Lab tests, I often don't do very many, but it's just your routine. You want to make sure there's not an infection, thyroid, electrolytes, calcium, a glucose, B12. If you think there might be an infection like UTIs are very common. Now, I just wanted to touch about, I'm just going to try to move this little box. It's in my way. Um, the cerebral spinal fluid analysis right now isn't really recommended. Even I have never ordered a CSF in my 15 years of practice, and they say that only experts should do them. It will change with the coming of the monoimmunotherapy that we're seeing in dementia, and that's also going to be not, it doesn't have to be CSF, but it can be like blood markers. And again, we'll touch. But I think for family doctors, you don't have to worry about ordering them to make your diagnosis. Oops, forward. So let's go back to Mrs. Forgetful, and you have a MOCA. She scores 25 out of 30. She's -3 on delayed recall, -1 on language. What's the diagnosis here? Okay, are we ready? Okay, so I'd have to go back. Yes, it could be MBI, but I probably would have called it MCI just because we have some evidence of her recall isn't as good. And we don't quite call it dementia yet because she still has all her functions, right? She's totally independent at home. So let's get a little bit more, oops, I keep pressing into that. But next question, what imaging would you do? would you do an MRI, a CT, or the FTG is like basically a glucose PET scan? We'll take another. Sorry, all my questions are up front. 33, 56, 11. Perfect. Okay. So just quickly, the MRI is always, of course, preferred, but in our healthcare system, we don't really have the resources, and I don't know if our radiologists will always approve it for a diagnosis of dementia. A CT is not unreasonable, but not needed. And a PET scan is very rarely needed, and we'll talk about that as well. What does the guidelines recommend? So again, MRI is really the gold standard for vascular lesions. Um, but it's not, as I said, it's not always realistic in Canada. I don't routinely order an MRI just when I'm sort of worried about a disease that might be identifiable on the MRI. If you order a CT, you can ask for the hippocampal volume or for them to specifically assess for if you're worried about dementia. The PET scan, our current Canadian consensus guidelines are really only should be ordered by experts. But I'll say one thing. I hope that by the end of this, you can, when you requisition or call a radiologist to see if you can have one, specifically if you're looking for Lewy body dementia, it might be readily accepted. Again, our guidelines say who should get a CT if you had head trauma, unexplained new neurological symptoms, seizures, especially if you have a risk of uh, cancer. So there's brain mets that you're worried about. If you've fallen or if you've gone, really, if the cognition has changed very quickly in the last 6 months, because then you're worried about something. If you think it might be normal pressure hydrocephalus, and if there's significant vascular risk factors, because then a CT is not so good at identifying those small vessel ischemic changes, although they will often comment on them, and I can certainly see them. I think you would be able to see them, but the gold standard for those small vessel ischemic changes is the MRI, of course. So let's go into the diagnosis. This is mostly for Alzheimer's dementia. What I do whenever I assess people, what goes through my head is just this balanced scale of how is their function and how bad is their cognition. And more recently, after I went to I was in Vancouver uh, for the new lecanemab drug, I've incorporated behaviors because I think sometimes we don't pay attention enough to behaviors, but I sort of weigh the two because they don't decline in similar fashion. Some people have like a very high education level, or for whatever reason, they're very good cognitively, or maybe they just come across, they have a good day in clinic. And then there's function, because really dementia is how is the cognition affecting the function? And that in the simplest way is what the DSM-5, how they diagnose it, is, you have a decline in the cognition and a decline in the function, and then a positive, like, objective evidence on the cognitive screen, which we already got. The way I explain cognition, because I always get my history from the family, is I say, cognition is like an umbrella, and these are the 6 domains that DSM-5 has: memory, learning. And I often just say, are they repetitive in questions? Do they forget recent conversations? And 9 out of 10 times, this will be your money question. And then I often go a bit further. I'm like, well, are they repetitive within a week, within a day, within hours, within minutes? And it kind of gives you a good idea of how advanced the dementia is. Language is very common. They struggle to find words. Are they reading and writing less? Executive function are things like, are they initiating get-togethers? Can they do multi-step things like filling out a form? Can they still cook a meal? Which is more function, but like a functional thing, but it's kind of how their thinking is. Complex attention, I'll say, are they multitasking? Like, can they watch TV while eating or conversing? Social cognition, I'm going to get in just a little bit more. but just are they more irritable, anxious, apathetic, less empathetic? And then perceptual motor is this new term we have for, you might recognize the terms visuospatial or praxis. Do they get lost, confused with dressing? Because even dressing yourself, I don't know if anybody saw the movie with Anthony Hopkins in it called Father, and it was about a man suffering with dementia. So dressing is a very 3D spatial task. And when people can't put their clothes on right, that's actually a visual spatial impairment. But often it's like you get lost in your house or while driving, or if you're in a new environment. Praxis, do they confuse objects like a TV remote for a phone? And often I don't ask that, but people will tell me that, which I find quite interesting. So I just want to get a little bit into behaviors, the neuropsychiatric symptoms and mild behavior impairment. Um, sometimes we thought of them as later life acquired, persistent, and impactful. But the NPS intrinsic factors are very prodromal, actually, and they can start very, very early, even before memory happens. So I start criteria, I forget the International Society. Sorry, it's escaped me exactly what it stands for. Will say as long as you're over 50 years and have had it for more than 6 months, it's a change from the usual behavior or personality, and it affects interpersonal relationships or social functioning or ability to work. So if you kind of have family telling you about that and you're asking what's going on, it might be something to kind of tuck away and think about as the patient progresses. Typical MBI symptoms are they're not as motivated, they're indifferent, they just don't want to do anything, they're anxious, more dysphoric, irritable. They have a harder time adapting to new routines. Like the common one I get is we moved houses and they just had such a hard time with that. Impulse control, also very common. People are agitated, disinhibited, gambling, obsessive. They perseverate. So a lot of these things may sound a lot like frontal dementia, but it's actually just it can be part of just regular Alzheimer's dementia. Social appropriateness, decreased empathy, loss of insight, um, and then abnormal perceptions or thoughts, delusions, hallucinations. I want to just review function. I rattle these off and I am very systematic about asking them. So these are I kind of ordered them from what you would think is the hardest down to the easiest basic activities of daily living. So just having a bath, dressing yourself, toileting, and that includes peri-care, like wiping. Transferring is just standing up and down, standing in front of a mirror, doing personal hygiene, and feeding. It's interesting that feeding yourself is one of the first milestones little children get around age 1. And it's literally the last thing elderly people will lose with dementia, the last milestone. Um, Bathing, of course, just takes a lot of, you have to organize how you get your clothes on, step into the shower, washing your hair. People will sometimes say, oh, yeah, they're in the shower, and then they just wash their hair over and over, like the whole bottle of shampoo will be gone. These are the instrumental activities, daily living. There is no doubt that finances is by far the hardest capacity item, and I will get into this in my last. It's very sensitive. You sometimes have to dig, because like even myself, there's very many levels of managing finances, like from the basic, simple tendering money to managing your investments. And a lot of things are automated, so people don't have to pay bills, or maybe they're just in a good routine and they go to the bank with their bills in hand, but the bank teller is paying the bills, right? So dig a little and just get interested in what does it mean to manage your own finances. Driving is, of course, important. Managing medications is so important because, we need to keep people compliant to keep them out of hospital, say with heart failure, meds and things like that, using a phone, meals, shopping, and then housework. And so the point to this is a lot of the times people can have advanced dementia, but they still Laundry is actually in there. I just kept it in with housework. People can still do those things like housework or yard work. This is kind of when I explain what is MCI versus dementia. And let me be clear about something. When I have people in my office, when I'm in this zone where I think, oh, I think they're more advanced than what their test score is giving me because they have full function, but they score quite low on a test, it doesn't really matter because what are you going to do different except maybe consider a drug? But it's kind of on a continuum, right? Like with the mild, what I explain to my patients is that they still have like normal function. And then if you had 100 people like that, 15 per year will lose some function. One of those ADLs or IADLs, usually the finances, and they'll progress to what we call mild dementia. Usually when you have like more than two or three IADLs, then you're in moderate dementia. And then severe is when they're like lost all their IADLs. Now on the bottom, I'm being sarcastic, like minor neurocognitive impairment. And again, we see MNCI, the same acronyms. Uh, and this is when I was at this regional advisory board with ESI, I asked if I could borrow this slide, and they were nice about it. What I really like is that in this preclinical Alzheimer's dementia, they talk about very mild changes like, somebody may have subjective cognitive disinhibition or have just some other symptoms. But then as they get more MCI or MBI, they have more of these symptoms. And of course, here you see you have no loss of function in the preclinical, no function, no impairment in the IADLs, and also ADLs. And then once you have mild dementia, this is really the cutoff. It's that function, right? Are they having function? And it can be very tricky because maybe they live with someone and they don't need to do a lot. I want to just have a quick word about cognitive screens. I don't rely on them a ton. It's kind of nice when the nurse comes back and I match it up against what my history and what my brain has come up with. But I don't like doing them for people who don't need them or if there's delirium. You need to be less than 26 to be positive. The Rootis is great if you have lower education or English is a second language. The MMSC, I said, is not as sensitive because of the recall problem of only using 3 words. The Mocha is my favorite by far. I prefer it over the slums. And I talked about that 8-point story at the very end, which is hard for people who have a hearing impairment. Now, the Alberta Blue Cross accepts all, and I put a little winky winky sign. They actually accept all of them except the Mocha. Go figure, right? And so, what I wanted to say often, like my nurse in clinic will go, well, it's really stressful. I don't want to do the Mocha because I know they need a renewal for their Blue Cross form, and the Blue Cross form doesn't accept the Mocha. It doesn't matter. I just tick off like whatever, I'll say slums and put in the Mocha score. And part of that fudging has come from, and we will talk about that in seminar 3 again, is if you are applying for Lewy body dementia, and these people really for the ARICEP Blue Cross approval form, they want to see a cognitive screen. They only allow it for like if you've done Alzheimer's dementia or mixed vascular dementia. So what happens if the score doesn't match the function? So if they have a really high score, like they're 22, often I'll see that if they have like a very high level of education or they're having a good day, and it happens. Like now, if the score is very low, it just means they have a lot of anxiety, maybe they're covering well, or they have a good routine or support. The other thing I find that if I can't have that be explained, I'll give you an example. I had a lady and I thought she was normal. She was actually there with her husband and she was managing the finances and she was quite independent. But then later on, her son, who was also a physician, asked me to assess her, and she was like a 14 or 13 on the MOCA. And I was so shocked that she talked so well in front of me and was managing the finances. But it turns out she was a manager of a bank, right? And that just shows you she was in a good routine. She just knew what to do, things that she had known her whole life. Now, if people score like, say, 20s, or like they have good function, they're in a good routine, but their score is really, really low, like in the low teens, and they're still really independent. I usually find that they can keep that up for a year or two, and then you get that drastic decline in function. Like they drop off. It's almost like they're falling off the cliff. And I've seen that. I see that often. So back to Mrs. Forgetful 1 year later, we do the MOCA, and now she scores 24 out of 30, -1 on the executive function, and -4 on the delayed recall. What would you like to do next? Start her on Aricept, refer her for lecanemab, which I'm going to tell you about, is this new monoclonal antibody therapy that you may or may not have heard or counsel for preventative factors. Okay, let's see what the answers are. People had a lot of Aricept, refer to lecanemab infusions. Great, I like it. Really, I should have put in, um, so we said uh, you can do A or C. You know what I didn't have, I should have had, is if she still has all her functions. Now, if she has all her functions, I would probably not start her on Aricept. And that's just because a well-done Cochrane review says it really doesn't show a lot of benefit in MCI, and we should reserve it for mild cognitive impairment. But we should always do for preventative measures, which I'm going to talk about in a little bit. And then let's talk about lecanemab because we're starting to see a lot of questions. So this is so exciting because literally in 15 years that I've practiced, we have not had any changes in drugs that we can offer. And if you have not heard, lecanemab is a monoclonal antibody, and basically it binds to the amyloid in the sort of in the fluid, and it removes it so that it can't get into cause these neurofibrillary tangles that cause brain cell death, um, and plaques and what have you not. The other drug is donanemab, and it is still with Health Canada, but I anticipate that it'll be approved shortly. Where are we with this drug? So it was approved in October, but it's not covered by Blue Cross, and we just found that about a month ago. Um, so literally after I give this talk today, I will be in our division meeting and we are trying to decide, uh, right now we're hoping to offer the drug and the patient for patients who can pay out of pocket. Um, it's about 33 to 40K a year, depends on your weight. So it's a year and a half long, 18 months. So it'll be about 55,000. So when you have people who are really gung ho, just ask them if they're able to pay that out of pocket. And then the other one is a commitment factor. They have to have an infusion every 2 weeks. Donanemab only has an infusion every month. And the indications for this drug is for MCI and mild dementia, so not moderate. So if you have more than two or three IADL impairments, your MOCA is under 17, this is not the drug for you. This drugs remove the amyloid early on, and they try to do it quickly. The contraindications are if you're on a DOAC, if you have homozygous ApoE, this is a genetic test, and if you don't have a caretaker to get you to and from the appointments and keep you and make sure that you're going to comply. So we have to, when we see these people, they need to confirm proof that there's amyloid, that there is this Alzheimer's. And blood tau markers are coming, and we will be sending ours to Vancouver. Again, I don't know. I think the patient will have to pay for this. It's about $250. They can also do CSF, which is more costly. I'm not really big on it. I think my next step would be actually, we do have some amyloid PET scans. The amyloid tracers are very expensive. We are in the process of maybe the university making its own tracers. So that's why radiology is kind of interested in testing some people. The genetics test ruling out homozygous. We don't want people that have a very high amyloid burden because then these people will be more prone to the side effects of ARIA H and ARIA E. And then we just need a basic MRI to make sure that their brain, that they don't have previous strokes. Again, that would potentially increase their risk of bleeding. And they'll need a scan at baseline and then 4 follow-ups. Now, the side effects stand for amyloid-related imaging abnormalities, edema, and hemorrhagic are the biggest ones. None of so a lot of these are found like they're asymptomatic. The way they kind of explain it is that when you're removing the amyloid, it causes a little bit of edema in the brain. But you see, sometimes people don't have any symptoms, and sometimes it can have these teeny tiny punctuate bleeds that don't worsen the cognition. But sometimes it may lead to bleeding. That's the big fear. There was no, in the lecanemab, uh, the Clarity trial, there was no major intracerebral bleeds. There was one, but it was after the study had ended. For now, Eastside will pay for the infusions, so they'll be handled by Bayshore. And we, as I said before, we are working on getting people set up and whether or not we will see them. I think we have to stand united as a group, just because, like, say, if I go on holidays, if I was the only one offering it, then who's going to answer calls and pages? What's our emergency corridor? All that kind of thing. This is the Clarity trial, and the way to infuse, this is the extended open label trial. They had like basically volunteers and put everyone from the drug into the treatment. But the way to understand that is somebody at 18 months, their cognition will be sort of close to 6 months. Like it'll kind of put them back to someone who is, 6 months earlier. And that can be quite significant for some people. Let's talk about prevention. Again, now when I was starting in 2010, there wasn't really a heck of a lot we were offering. We're saying keep your hypertension controlled. And then right around the pandemic, the last recommendations of the Canadian consensus guidelines for, we call it the CCC-DT, whatever, came out. And it was very helpful. And it basically identified these factors: nutrition, exercise, hearing was a big one, like identifying people with hearing impairment, making sure people are getting good sleep, cognitive training, keeping them, engaged, frailty, managing frailty, and also minimizing highly anticholinergic medications. And then around the same time, from the Lancet, I really like the Lancet. I find it a very progressive journal. The 2020 report of the Lancet Commission came out. They've had another one since then in 2024. All of these will be in the references. And they draw these beautiful, I don't know what they're called, picture diagrams. And I don't know if you can see, but the preventable. So what this has done, just to put it in, this is kind of like the Framingham study in Norway, where I think it's called the Hunt study, and you can buy this data if you have a lot of money. But you literally, every single person in this community, they know everything about them. And so they do this risk factor assessment. And what they found is from they identify more and more factors, mostly in midlife, but they're very strongly saying that even in later life, you can still work on these factors. Up to 45% are potentially modifiable risk factors. And so I see people later in life, you guys will see them earlier, but this is something you can do teach your people and tell them about. And the big ones that they identified are hearing loss, treating the LDL cholesterol, depression, traumatic brain injury. I mean, hard to treat, but just telling people about, wearing a helmet, being safe, physical inactivity, smoking, diabetes, hypertension, obesity, not being socially isolated. I think air pollution is becoming so much more important, especially with our smoky summers, and also making sure that people have up to date vision. The way I explain vision and hearing to my patients is that it provides sensory input to the brain. And despite what everyone thinks that the brain doesn't change after age 30, even at age 70, we still have some plasticity in our brain. Forming new like little highways around the damaged ones, not as fast, of course. Um, but especially hearing, because what happens with hearing is that your brain gets that information. And unlike vision, like our vision, the way we process stuff is basically completed at age 3, right? We see something and just how those networks work, that's done. But with hearing, we don't know what someone's going to say. We have to interpret it. We have to formulate an answer. That takes a lot of brain work. That's stimulating your brain, right? So really, really get after people to get their hearing assessed and invest in hearing. So this is what I can say. You can say to your patients, get those up-to-date prescriptions, get them involved, get them to stay involved. It's really hard because people hate big crowds and it gets almost overwhelming with the noise. But small, like staying involved with your friends is so important. Treat the blood pressure. We're back to treating as normal if possible, but just don't, of course, take into consideration what their frailty is if they can manage it. Treat their depression, treat their LDL. You don't have to stop the statin now. Ask about snoring and how their sleep is. I personally, from personal like experience with my patients do so much better when they're on a CPAP. I know it's uncomfortable. Getting to them to be active and walking, a healthy diet. You know all these things, right? Especially the soluble fiber. We're learning more and more, a microbiome, and just activity, just anything that they want to do. This is the stuff you can encourage your patients to do. So she's 2 years later. She has full ADLs, but now her daughter, she's lost that ability to manage her finances. Her MOCA has dropped a bit more. So now how would you treat it? We have our last question. Would you start the Aricept counsel, stop mirtazapine and start Aricept, all of the above, E and B? I think I might have ignored C because we might not have started mirtazapine um, but anyways, let me know what you think. Okay, let's see what people have. Um, Perfect. All of the above, yes. I don't know if I had mirtazapine. Anyways, I'll take it all. Yes, you would offer, and that's the thing about acetylcholinesterase inhibitors. I might just say Aricept from now on, but also you can also do another one like rivastigmine. Is what you'll find is a lot of people can't tolerate them, and we'll go. Oops, sorry, wrong forwarding thing. So just a quick reminder of acetylcholine. So early on, when people thought about a cure for dementia, they saw that there's maybe a decreased neurotransmitter, acetylcholine. And this is important because it doesn't improve the memory, but it just improves the network processing. So it can help with learning, attention, memory, but it also has all these other side effects. It's very, very vagotonic. So if you have someone on AFib and a beta blocker, and that's something you can work with, right? But it also potentiates heart blocks, cardiac output. It can cause bronchoconstriction, more mucus secretion, more GI secretion and motility, and it can also increase bladder contraction. So if you have people with urgency and that's more important to them, or more, should I say, functioning is harder on them, then you have to talk to them about that. So basically, what they do is there's an enzyme, that's what the inhibitor is, slows that enzyme. So then we just have more of the neurotransmitter in our synapses, and hopefully we get those positive brain effects. But the most common side effects is the nausea, vomit, diarrhea. And that's why I say go really slow, start at 2.5 if you're using Aricept, measure the baseline weight and repeat. Avoid if the person has a big history of weight loss. A very rare side effect you'll sometimes get is that it causes vivid nightmares. I've seen it like 2 or 3 times. It's very vagotonic on the heart. So I always get an EKG. I look at it. If there's you decrease the beta blocker if you can. I generally will still sometimes offer it in a first degree heart block, but and maybe the right bundle branch, but definitely not if it's a left bundle branch. Uh, so I do the baseline EKG and then I'll repeat it. What I always teach this student is if they have severe, think of it as making you more wet. So if they have bad COPD, heart failure, or peptic ulcer disease, you probably don't want to rock the boat. And then the other one is, of course, it can lower seizure threshold. So that's kind of how I would do it. And a lot of people you will see will have some of these. This is the original trials. These are kind of the curves you can sometimes show people. Um, and this one was published in neurology, but also Annals of Internal Medicine. And what really threw me off is that when you look at this score, like it's kind of stretched out, the ADAS-Cog score is actually on 74 points. And so you see maybe a little bit of improvement, placebo as well. And then, of course, you get the decline over time, and you kind of get the decline as well in the Aricept. But having said that now, the drug can be quite not beneficial, but it means different things to different people. It can help with behaviors and as a result, probably decrease caregiver burden. And in the States, it actually slowed long-term care placement by 3 or 4 months, which I think was one of the reason the drug was readily accepted by the FDA. It means different things. Like I had somebody who was in a third-degree heart block, and I saw him in hospital, urged the family to get him off. And they were like, no, don't you dare stop this drug. With this drug, he can remember our names. And that meant everything to them. So I just explained what the side effects were, and they were okay with that, right? And often I leave it up to sort of family and the patient. So basically, take home messages. The diagnosis of mild cognitive dementia and mild dementia is clinical. Prevention, like there isn't a lab test or a CT that will give me the diagnosis. It's just getting a history of the cognitive impairments and the functional impairments. And then you can throw in a cog screen to have a little bit more objective evidence. Prevention strategies include maximizing sensory input, optimizing vascular risk factors, and just encouraging your patients to be active, eat a healthy diet, and stay socially active. Lecanemab and other immunomodulators may be available in the near future, but right now not covered by Alberta Blue Cross. I think the story is not finished. They're appealing it, so we'll see what we hear. And acetylcholinesterase are very reasonable in mild dementia, but not MCI. And that's the end of the talk. If there are any questions.
Thank you very much for that really practical talk. And here we do have some questions. So the first question we have is, would you consider the MOCA basic for those who have education less than grade 8 over the root S?
Would it be, no, I would, so on the Mocha, they have an automatic, like you can add a point if they have just gone to high school. But if they just have elementary, in Ontario, grade 8 is elementary school. I think it's a little bit different in Alberta, but I would probably just do a Rootus on them. Good question.
The next question is bradycardia and acetylcholine inhibitor. If baseline 50s but no symptoms, watch carefully or avoid.
Ooh, you could, okay, so here's my stance on that. In my top three, there is one population I push for, and that'll be my Lewy body dementias because they are so deplete of acetylcholine and they do so well on this drug. Low 50s is pushing it. I may give them 2.5 and see how they respond. If you don't have any room to move, it probably wouldn't be worth it because I don't know if you guys have ever had a low heart rate or been on a beta blocker. It doesn't feel good. So no, I would probably explain it to them that I just think it's not worth it. But if it's Lewy body dementia or Parkinson's disease dementia, ooh, that would be close. And you can monitor the heart rate. Like sometimes you just get a close one in clinic or it's related to the beta blocker, as I said. But generally, no.
Thanks. If the patient has presyncope, syncope, NYD, and ECG normal, do you stop the Aricept?
I w I would maybe dose reduce it and see if it's better. I don't know if that helps you or not. So if it isn't really known to cause presyncope, so that may be due to something else. It's like you're constantly weighing the risks and the benefits. Sometimes what you do is when you start it, it's kind of like SSRIs, right? Like you try it, you say, okay, why don't you try taking it every other day and just give them that longer period. And please start at 2.5 and just say, why don't you stop for a day and then try again if they're very keen to do it. But it shouldn't cause presyncope. That's usually maybe from something else.
And I will just extend that question in terms of like starting at 2.5. Do you ever do like Q2 day dosing or even quarter pills? Do you ever go try
Yeah,
some of those regimens?
yes, you can certainly try those. And a lot of my colleagues don't, and I think we don't do it enough. They just go, oh, they didn't tolerate it. But a lot of these drugs, if they're really helpful, if people are really keen on it or they're like that population, I have never ordered a quarter pill, but you can try it. I think it's doable. And yeah, go to Q2 dosing and just see if they can tolerate it. And if it makes people feel really bad, they won't want to be on it. And then it's okay too.
Um, just to complete the questions around that, bradycardia with a pacemaker, would that
You're
be?
you're good to go. Don't worry about it. Put them on it. You can have a left bundle if the pacemaker is in there. It's like boom shakalaka. You can now prescribe safely. I know. I always wondered about that too, but it's like, is there a pacemaker to help me?
The next question, is there anywhere you would use a neurocognitive, or is there anywhere would you use a neurocognitive assessment?
Like for like the one that we would send to the Glenrose for the 3 hour ones. Is that what you're saying? Is that what the
I
question is?
think so. Yes, I
Yeah, yeah,
think
yeah.
like for additional
Yeah.
supportive
Okay,
testing.
so here's my take. When I was a fellow at Harvard, I had to sit through one of those, like just watching, and I almost died. So the question is, yes, I send it, but not for routine Alzheimer's. It's just if they're a really young person with early onset, and if they can handle it, and if they're like frontotemporal lobar or maybe like multisyst, like you're just wondering, usually for frontotemporal lobar and some of those other Parkinson plus syndromes that we will talk about in the third, they take a long time, right? So it's just if you really wonder what the diagnosis is, then we would send them, yes, but not routinely. You'll get turned down. And I haven't ordered one in years now, to be quite honest.
How sustained is the benefit of staying on lecanemab once a patient starts it?
I just don't know. I've never prescribed it. Some people are doing it, have been on the drug for 4 years, and then I think they kind of decline. But we're just at the 4 years. And some people report, so your buying time, your level stays higher. In theory, you decline, maybe not as fast, but we just don't know. I don't have any evidence to tell you how sustained it'll be.
So the next question sort of relates, and somebody's asking, are you using lecanemab in your practice, and when will it be more readily available? So I think.
Yeah, so sorry if you missed that, if I wasn't clear about it. No, I am literally meeting with we have a division meeting today. I think we should offer it privately, and I think a lot of my colleagues are concerned. So we have to unite as a group to offer it. But right now, we just don't have, we're working on just provincial kind of having it in place, how that they all get treated the same way. And we need a bit more. I'm hoping in 3 to 6 months, in 3 months at the earliest, or maybe latest 6 months, we will be able to treat people in clinic. And just to put it in perspective, Vancouver just started, so they're kind of treating privately, and they started mid-February. And this is very, very new.
And they're paying 35, 40K
Yes,
per year.
so that's correct. There is one, like I think Eastside gave a couple of freebies. So if you hear of somebody who's getting treated for free, I know one of the neurologists kind of got 3 free full treatments, like where the drug company is paying, like they gave me, for example, a free pay for they were paying for p-tau 17 because they wanted us to have practice. So if you hear of a neurologist who's treating people, I spoke to him a week ago because we actually had an overlap in patients, and he literally said he has 3 free trials, um, but it's not covered right now. That may change. That may change.
Can we have one last question? So there is somebody asking about ApoB or apolipoprotein B or ApoB to assess risk. Is there any role for the use of ApoB?
In MCI, um, I would say no. The Canadian consensus guidelines say no. So the reason we do ApoE is because if you're homozygous, you have more amyloid, and that puts you at more risk of bleeding or having edema. Now, the Clarity trial, did have 5% of homozygous and a slightly higher risk. But I may have a copy, like a single copy of ApoE, and may not, it may not make me have dementia. And people who have dementia sometimes don't have a copy of ApoE. Does that make sense? But we know that if you have 2 copies of ApoE, you are much likely to have a higher level of amyloid in your brain. And that's why that test is being done. But no, you shouldn't go out and test it because you won't know. It's just you don't know exactly what their risk is of actually when they'll start having dementia, and what it'll be. I know some people like that Thor, that hunky actor Chris Evans had his ApoE tested and he was homozygous. Um, but no, we're not routinely offering it to help diagnose dementia. Is that
Thank you.
helpful?
That was helpful, but I believe this person is asking about apolipoprotein B, like the lipid marker.
Oh, yes. I will leave that in your hands. Like, I don't know. I wouldn't say if you test that, sorry, I misinterpreted. But if you do that and then you determine that they are at risk for LDL, my own judgment would be that yes, you treat them. And it's very, again, not a ton of it's very interesting, but I think rosuvastatin is the choice. Just and there was a large trial from Brazil that had like, again, it's a meta-analysis, but yes, I would test for LDL and treat it if possible, if it needs treatment.
Thank you. And actually, one more question, and we'll end on this one. What about the first and main change is word finding? Should screening be done?
So can you say that again, Rose?
Word finding difficulties. Word finding difficulties.
Yes. And I sympathize because I feel like I sometimes have this when I'm tired, uh, you know, or like remembering I have so many patients, I can't remember my patients' names. But if it becomes like if they say it was just when I'm tired, it doesn't hurt to do a mocha. I just wouldn't routinely do a mocha if you don't have like language, like that's a recognition, that's a domain problem. So if that routinely happens, yeah, sure, do a mocha screen and see where they are, right? But just remember, like, if they have like lost a couple of points, just reassure them it's not, because I think what people's biggest fear is that they'll be hauled away to a long-term care. Just say, hey, you have many years left of enjoying life, many things we can try to do to slow it down, like those preventative factors. And your life isn't changing from the moment you walked in the door, the moment you walked out. Like, I try to be very positive about it. So, but yes, you can do a mocha if you want to, or if the patient agrees to it.
Thank you so much for that great webinar. And please complete your evaluations. Your feedback is greatly appreciated, and your suggestions for future webinars are greatly appreciated. So we will leave it at that. And if you've got further questions, I see there's one more, but we'll maybe mention it for the next time. We'll maybe leave it for next time. Okay, hope to see you next week. Same time, same place.
Thank you,
Uh,
everybody. Leave a review if you can. It helps us in the hospital, academics.
yes, thank you so much, Diana, and thanks everyone for joining, and look forward to the next one.
Bye.